One of the few things that both Donald Trump and Hilary Clinton seem to agree on is that high out-of-pocket spending, specifically as it relates to the Affordable Care Act, is a problem. One of Clinton's most popular healthcare proposals during her campaign was to reduce out-of-pocket spending to more manageable levels for many Americans. President-elect Trump sought to fix this problem by repealing the ACA and replacing it with something better. Reducing out-of-pocket spending, however, will require some trade-offs. No easy solution exists, but there are examples out there worthy of consideration. That's the topic of this week's Healthcare Triage. Before we can discuss any plan specifics, it's worth reviewing exactly how health insurance works. Plans differ on the amount of actuarial value they have, which refers to the percentage of the cost of care that insurance will cover. If a plan has 60% actuarial value, then it covers 60% of your potential healthcare spending, and you cover 40%. Plans with higher actuarial value cost more in terms of premiums. In the insurance exchanges, bronze plans have a 60% actuarial value. Silver plans are 70%, and gold plans are 80%. The money that you pay up front for health insurance is called a premium. Those are often charged monthly. That's what you see when you find out how much a plan costs. But that's not all the spending you'll do. Almost all plans come with deductibles. This is the amount of money that you're responsible for paying even after the premiums before insurance coverage kicks in. The reason plans have deductibles is that research shows you're less likely to spend your money than someone else's money, the insurance companies. Plans with lower deductibles usually have higher premiums. Not all care is subject to the deductible. Most preventive care is fully paid for by your insurance. Even after you spend the deductible, you're not done though. Most plans come with copays. These are set fees that you have to pay each time you access the healthcare system. They could be $20 for a doctor's visit or $100 for an ER visit. Some plans use coinsurance instead. That's when you pay for a percentage of your care instead of a set fee for each service. The lower the actuarial value, the more you're going to pay out of pocket in deductibles, copays, or coinsurance. But plans in the exchanges are all subject to an out-of-pocket maximum. For a family, in 2016, it was $13,700. And for an individual, it was $6,850. Even the bronzest of bronze plans can't ask you to pay any more, but they're more likely to let you hit that maximum. That's a lot of money. And as we've discussed before at Healthcare Triage, while uninsurance has gone down, many Americans are still underinsured, meaning that they're exposed to significant financial risk from out-of-pocket payments. This is true even in the employer-based insurance market. In 2016, almost 30% of workers were enrolled in a high-deductible healthcare plan. More than half of employees with individual plans had deductibles of at least $1,000. Two-thirds of covered workers had copays, and 25% had coinsurance for primary care. Almost 20% of workers were in plans with an out-of-pocket maximum of $6,000 or more. Secretary Clinton proposed improving this problem with a tax credit for those with high out-of-pocket spending of up to $5,000 per family or $2,500 for individuals. This tax credit will be applied to covered Americans whose out-of-pocket healthcare spending rose above 5% of their income. Economists at the Rand Corporation modeled how this proposal might work. They estimated that this cost-sharing tax credit would increase the number of insured people in the United States by 9.6 million people in 2018. They also found it would lead to significant reductions in out-of-pocket spending for many Americans. Most of those savings would have been felt by those making between 139% and 400% of the federal poverty line. People earning less are usually on Medicaid, which has little out-of-pocket spending already. And people earning more are less likely to see such spending reach the limit because of their higher income. The trade-off is that this would have cost money. Quite a bit of it, in fact. It's estimated that the tax credits alone would cost more than $110 billion in just 2018. Some of this government spending would be offset by people choosing to take private insurance with the credits over Medicaid, which could reduce Medicaid spending by $25 billion. Overall, the economists estimated that this policy would increase the federal deficit in 2018 by just over $90 billion. Of course, this could be offset by new taxes or fees, but those would have been unpopular, and none of them are going to happen anyway. President-elect Trump offered no specific plans for reducing out-of-pocket spending, But that's not surprising. It wasn't that long ago that one of the most favored means by which conservatives proposed to bring down healthcare spending was to have more consumers put more skin in the game. Many of them believed that if consumers were more exposed to healthcare spending, if they had to pay more out of pocket for care, then they would be more responsible consumers of it. In fact, calls have already begun for President-elect Trump to expose people to even more out-of-pocket spending. Right now, the Affordable Care Act has provisions that help reduce cost sharing below the out-of-pocket maximum for those making less than 250% of the poverty line who purchase a silver-level plan. Those payments are made directly to health plans that cover those people. It may be possible for him to cut off those payments immediately upon entering office without any congressional involvement. If he were to do that, it would either cripple those insurance companies or they'd withdraw immediately from the exchanges, terminating coverage and leaving millions without health insurance overnight. It's unlikely that this is how President-elect Trump would want his first few days in office to be covered by the media, but anything's possible. It's also unlikely that the Trump administration would follow a path to cover more people's out-of-pocket payments with federal money. To argue suddenly that people should be shielded from the expense of healthcare would be a sea change on conservative health insurance design. That doesn't mean that there aren't changes that might make sense, though. In other countries, like France and Singapore, which we've covered before, cost sharing for those with chronic illnesses, who might spend the most on healthcare, have their copays waived or reduced. The theory there is that we want to use cost sharing to drive those who are healthy to spend less, but remove barriers for those who are sick. Changes such as this might leave in place many of the benefits that cost sharing is supposed to provide in curbing spending, while removing the harms of high out-of-pocket spending for many vulnerable Americans who need care the most. Regardless, out-of-pocket spending was an issue throughout the campaign, and it's not going away soon. With or without the ACA, it's likely an issue with which the Trump administration will need to grapple, while providing solutions that satisfy campaign promises without abandoning conservative principles of reform. Healthcare Triage is supported in part by viewers like you through Patreon.com, a service that allows you to support the show through a monthly donation. Your support makes this show bigger and better. We'd especially like to thank our research associate Joe Sevitz and thank our Surgeon Admiral Sam. More information can be found at patreon.com/healthcaretriage.